All right, let's dive right into a high-yield, evidence-based review of hip anatomy. This is specifically designed to get you ready for the OCS exam. We're going to skip the fluff and focus on the details that really matter in the clinic. Let's get started. So let's kick things off with a classic clinical puzzle. A patient walks in, and you immediately notice they have a pretty significant in-toeing gait. So what's going through your head? Your differential diagnosis list starts running. Is this coming from the foot? Maybe it's a tibial torsion thing, or could the real problem be coming from way up at the hip? Just keep that question simmering in the back of your mind. We will circle back to it, I promise. So here's our game plan. We're going to tackle the hip systematically, basically building it from the inside out. We'll start with the OCS blueprint, the bony architecture itself. Then we'll layer on the passive stabilizers, the labrum and ligaments. After that, we'll get into the muscles, the dynamic engine of the hip, followed by the super important neurovascular structures. And then we'll tie it all together with a clinical case and some quick retrieval practice to make sure this stuff really sticks. All right, section 1, the osseous blueprint. We have to start here because, as you know, the shape of the bones dictates everything. Function, pathomechanics, you name it. Tiny little variations in these angles can have huge clinical effects all the way down the chain. First up, let's look at the angle of inclination, which is in the frontal plane. In adults, normal is somewhere between 120 and 125 degrees. Now, if that angle drops below 120, we call it coxa vara. Clinically, this can show up as a leg length discrepancy, but what's really important is it messes with the glute abductors, making them functionally weaker. On the flip side, if the angle is greater than 135 degrees, that's coxa valga. This setup makes for a less stable joint because you lose some of that nice snug congruency. Now let's rotate into the transverse plane and talk about the version angle. Normal here has a pretty wide range, about 8 to 20 degrees. And this brings us right back to that question I asked at the beginning. Femoral anteversion, that's an angle greater than 20 degrees, is a major cause of that in-toeing gait. To make the joint feel more congruent, the person just naturally internally rotates their hip. And the clinical sign you'll see? A ton of hip internal rotation with not much external rotation. The exact opposite is true for retroversion, where the angle is less than 8 degrees. They'll present without toeing, and you'll find they have tons of external rotation but very limited IR. The bottom line is this: version dictates rotation. Okay, so let's shift our focus to the socket, the acetabulum. We measure how well it covers the femoral head using something called the lateral center edge angle, or LCEA. And here's a number you absolutely have to know for your exam: less than 25 degrees. A value this low means you've got acetabular undercoverage. This is the hallmark radiographic sign for hip dysplasia. Basically, there's just not enough of a bony roof over the femoral head, which can lead to big problems with instability. Now, moving from the socket to the ball, specifically the femoral head-neck junction, we look at the alpha angle. An alpha angle that's greater than 60 degrees tells you that the femoral head isn't perfectly round. This extra bone buildup creates what we call a cam deformity, and that is a classic sign of femoral acetabular impingement, or FAI. And this leads us right into the big topic of FAI itself. This is hands down one of the most common causes of hip pain in people who don't have arthritis. At its very core, FAI is just an abnormal, early contact between the femur and the acetabulum. Why? Simply because the bones aren't shaped quite right to move smoothly together. So FAI basically breaks down into two main types. We just mentioned cam FAI. That's a problem with the ball, the aspherical femoral head, which we measure with that alpha angle over 60. Pincer FAI, on the other hand, is a problem with the socket, the acetabulum. In this case, there's too much coverage. The rim of the socket is too deep. A good number to look for here is a lateral center edge angle over 40 degrees. And just remember, it's super common for patients to have a mix of both types. Okay, so we've got the bony framework down. Now let's start adding the next layer of structures, the passive restraints. We're talking about the tissues like the labrum and the ligaments that give the hip its built-in static stability. The acetabular labrum does so much more than just act as a bumper. You should think of it like a high-performance gasket. For one, it makes the socket deeper, which gives more surface area for the joint. 2, it creates this incredible suction seal that adds a huge amount of stability. 3, and this is so important for joint health, it helps spread out forces across the cartilage. And clinically, a key point is that it has a pretty poor blood supply, which, as you know, has big implications for its ability to heal. And this really hammers home why a labral tear is such a big deal. This quote from that pivotal 2003 Ferguson study says it all. When the labrum is damaged, you lose that force spreading function. So instead of the load being distributed nicely, it gets concentrated onto a tiny area of cartilage. And over time, that focus pressure is a direct pathway to cartilage damage and eventually osteoarthritis. Okay, let's do a quick tour of the three big ligaments on the outside of the joint. First, we've got the iliofemoral ligament, also known as the Y ligament. This thing is a powerhouse on the front of the hip, seriously one of the strongest ligaments in the whole body. Its main job is to stop extension and external rotation. Next up, the pubofemoral ligament, which sits anterior-inferior. Its job is mainly to limit abduction and also helps limit extension. And finally, wrapping around the back, we have the ischiofemoral ligament. This is your primary passive check against internal rotation, and it also helps with extension. The big picture here, all three of these guys get tight and work as a team to limit hip extension. All right, we've got the bones and the passive restraints locked in. Let's talk about the dynamic system, the muscles. These aren't just for moving the leg. They are absolutely critical for controlling movement and dynamically stabilizing this entire complex. Okay, listen up, because if there's one muscle group you have to know inside and out for the OCS, it's the hip abductors, the gluteus medius and minimus. Yeah, sure, in an open chain, they abduct the hip, but that's not their most important job, not even close. Their critical function happens when you're standing on one leg. They fire like crazy to hold the pelvis level in the frontal plane, preventing the other side from dropping down. This is the entire basis for the Trendelenburg sign. Now here's a really cool, kind of mind-bending biomechanical concept. The adductors can play for both teams. They can be flexors and extensors. It all depends on the position of the hip. When your hip is in extension, the adductor longus and brevis pull from the front of the joint's axis, so they act as hip flexors. But as you bring the hip way up into flexion, their line of pull shifts to the back of that axis, and suddenly they become hip extensors. This is a crucial concept for understanding things like the pedal stroke in cycling. You know, this is a super common point of confusion. We have this nice, dedicated group of deep external rotators, but there's no single muscle that's the primary internal rotator of the hip. It's just not a thing. Instead, internal rotation is a group effort. It's a secondary action produced by a bunch of muscles working together, like the front fibers of the glute med and min, the TFL, and even some of the adductors. Okay, time for a quick clinical terminology update. For years, pretty much any pain on the side of the hip was just called trochanteric bursitis. We know better now. The modern, more accurate term you should be using is greater trochanteric pain syndrome, or GTPS. And this term is better because the evidence now clearly shows that the main issue is usually a tendinopathy of the glute med and minimus tendons right where they attach. That inflamed bursa, it's often just a secondary finding. All right, we've covered the frame, the passive restraints, and the dynamic engine. Now, let's briefly touch on the power and communication lines of the hip, the neurovascular structures. Understanding where these are is so important for your differential diagnosis and, frankly, for not causing any harm. The femoral triangle is one of those anatomy landmarks you just have to have locked in cold. The borders are the inguinal ligament up top, the sartorius on the lateral side, and the adductor longus medially. But what's inside is even more important. Just remember the mnemonic NAV, going from lateral to medial, that's nerve, artery, vein, and lymphatics. This is your spot for checking the femoral pulse, and it's a hot spot for hernias and nerve entrapments. And this right here. This is a huge deal for the health of the femoral head. Its main blood supply comes from the medial and lateral circumflex femoral arteries. If that blood flow gets disrupted, often from a bad fracture or a dislocation, it can lead to avascular necrosis, or AVN. That's the death of the bone tissue, and it can cause the joint to collapse really, really fast. Okay, we've absorbed a ton of anatomy. Now for the fun part. Let's put it all together and make it clinical. In this last section, we'll run through a case and do some quick-fire questions to really make these concepts stick for the clinic and for the exam. So, picture this. Your next patient walks in. He's a 24-year-old guy who's a serious runner. He's got this deep, achy pain in the front of his hip that gets worse the more he runs, especially on hills. You bring him through your exam, and the FAI test, that's flexion, adduction, and internal rotation, lights up his specific pain. So, what's your diagnostic hypothesis starting to look like? So, let's be the detective here. We've got a young, active guy with anterior hip pain and a positive impingement sign. Given everything we've talked about, what specific bony shape should be jumping to the top of your list? And if you were to get imaging, what specific measurement would you be looking for to seal the deal? Think back to that OCS blueprint section.
All right, time for a little retrieval practice. This is how we make the information stick. 3 quick questions. Number 1, what's the main ligament that limits hip IR? Number 2, when you're standing on one leg, which muscles are the superstars preventing that pelvic drop on the other side? And number 3, an LCEA of 20 degrees points to what specific diagnosis?
Okay, let's see how you did. The primary passive restraint to internal rotation is that posterior ischiofemoral ligament. The muscles preventing that pelvic drop are, of course, the gluteus medius and minimus. And an LCCA of 20 degrees, which is below our 25-degree cutoff, is the classic sign of hip dysplasia from undercoverage. And what about our runner? Well, the top suspicion has to be a CAM-type FAI, and you'd confirm that with an alpha angle greater than 60 degrees. Look, I know that was a lot of information. So if you're walking into your exam and your brain is fried, these are the 5 things you absolutely cannot forget. 1. Version dictates rotation. 2. Know your key angles. LCA under 25 is dysplasia, alpha angle over 60 is CAM-FAI. 3. Ligaments have specific jobs. Iliofemoral resists extension, ischiofemoral resists IR. 4. The glute med is the king of the frontal plane, period. And 5. With lateral hip pain, think glute tendons first. Think GTPS, not just bursitis.
And I'll leave you with this one final thought. We've just gone deep into the static blueprint of the hip joint, but we know the body doesn't work in a vacuum. So the question to really chew on is this. How does a structural thing like femoral anteversion or a pincer impingement dynamically change how someone moves? Not just at the hip, but at the knee, the ankle, and all the way up into the low back. That's the next level. Thanks for your attention.